Our next speaker is going to be Dr. SUMEET LAHANE, and he is the assistant professor of the Grand Medical College. And by the way, he also wanted his video to be shared, and Sir JJ Group of Hospitals, Mumbai, and he has a wonderful teaching video for us. Dr. Sumit, are you there?
Yes, ma'am. Yes, ma'am.
Yeah. Mr. Sharik, can you share his video? I forgot to tell you about Dr. Sumit. He's in a place where the signal is not, the network is not good. Could his video be shared?
Very good afternoon. Yeah, very good. Can the
Video
music be lowered of my video? Yeah. So very good afternoon. Thank you, Chitra ma'am, and everyone for giving me a case of a mature cataract which I have started operating. And the most important thing that we feel the rhexis should happen properly. I try to do a good rhexis, help me with the forceps, and I think that's it. Now the rest of the cataract, though mature, but was a soft enough. So I started my phacoemulsification. I wanted to do a direct chop, but somewhere I was struggling to hold the cataract in my phacoprobe, trying to rotate, but not happening. And suddenly I noticed there is a deepening in the anterior chamber and not able to basically hold the phaco. So it's basically I'm trying to catch the lens and lens is going back. Now you see that snapshot, the pupil is getting constricted. And basically as I'm trying to hold the cataract, it's basically pupil is getting constricted, dilated again. My heart is pumping more and more with that, but I'm not able to proceed with the first step itself. And what is happening here exactly? The anterior chamber deepening, pupillary dilatation, and the concave iris, which is not letting me hold the lens, and I'm not getting anything to go ahead with. So this is basically what we are dealing with, the lens iris diaphragm retropulsion syndrome. Now, what I realized that incidentally what has happened with me is there is a capsular tear, and I realize now I need to reduce my bottle height. I reduce the bottle height and things become much simpler now. The patient was of course complaining of pain, but that was reduced with the topical anesthesia itself, and reducing bottle height helped here. You can notice that the pupillary constriction which was happening, that also reduced. And I could basically finish my surgery. So what exactly happens here is that there is a weak zonular support and there is 360-degree iridocapsular adhesion that happens in such cases. A few things that we need to know, that it's a myopic patient, many times vitrectomy is a young patients in which all this happens. There are very simple ways to manage. One is to reduce the infusion bottle height and the flow rate. Another is you can add a AC maintainer while you're doing a surgery. This is the anterior chamber maintainer, which it can be added through a simple side port. Extend the rhexis, which happened in my case, and basically you can avoid the iris capsule adhesion, which is important. So basically you can manually also separate the iris from the anterior capsule, which is one of the very most effective way while you operate. Thank you all for your patient listening.
Thank you very much, Dr. Sumit. That was a wonderful learning tip which you tried to show in your video, and thanks for being there in spite of the personal tragedy at your home front. And I'm very thankful on behalf of ARC for your presence here. Now, the question which I would ask Dr. Rohit Om Prakash about this case of a high myope. I'm sure the first thing which we should do is to lift up the iris from the lens surface so that the anterior chamber and the posterior chamber pressure equalizes. But here there is one other thing, two things which have happened. One is a deepening of the anterior chamber and a rhexis extension. So what would you advise about the parameters or the steps of the surgery in these particular cases, Dr. Rohit?
I think it has to be, it was brilliantly managed by Sumit as always. One thing which, this is something which happens in myopes, high myopes. This lens iris diaphragm retropulsion syndrome. in which the pupil constricts and dilates. And as you have already said, lifting the iris is a very important thing. And in all, as he said, there was a pain, and the patient was saying that he was having pain. In these patients, low IOP phaco is a very important factor, which should be managed. And because the chamber was fluctuating, there was an anterior capsular tear, which resulted in all these things, but it was a perfectly managed situation. So in all these patients, what is required is that you have to lift the iris whenever required, because when you will lift the iris, the pupil will then come back to normal. And a low IOP phaco has to be done in these patients.
Satyajit, do you have anything to add? Any other
No, ma'am, I
questions?
just commented very nice video by SUMEET.
Yeah. Would you have something to add about your flap motility sign, Dr. Rote Om Prakash, in these cases?
I think if the anterior capsular tear, if it extends to the periphery as it did, then if it is a pre-equatorial tear for that matter, so one should enlarge the vision by having a look at the anterior capsular tear. If the tear by any means is fluttering and it is everted, by all means it states that it is pre-equatorial. And if by any means the moment you feel that it has stopped fluttering, this means it's in the process of extending back, and that is the time when you should convert. So these are the things which you should bear in mind. And in these patients, you have to use, as he did, you should use safe phacoemulsification techniques also. There has to be minimal rotation. The separation has not to be, at 90 degree to the anterior capsular tear, because that will cause further extension of the anterior capsular tear onto the posterior aspect. So the site of the incision has also not to be parallel to it. Supracapsular phacoemulsification should also be carried on in these patients. So this is what flap motility sign will help you, because it will help you when it is going to be the end point of safe phacoemulsification.
Thank you very much, Dr. Rohit. I think you have brought out all the relevant points. Dr. Ramurthy, Dr. Saurabh, Dr. Madhukar, any of you want to add anything at this point? Or do we go on?
One more thing, because all of us don't have the IOP controlled machines probably. So
Yes.
what I do in high myopes is that if we have a motorized pole, I see to it that the rise in the IOP is gradual. So we start off with a lower bottle height, and gradually we can increase it. That reduces the chances of sudden deepening of the anterior chamber. And we get also time to flick the iris up, so patient is more comfortable, particularly on topical anesthesia.
Dr. Ramurthy, would you like to add about the IOP ramp being played around with in these cases?
Before that, I would like to say something more basic, in the sense that very nicely managed, Sumit. Just that you mentioned that AC maintainer might be one aspect which might help, but I somehow do not agree with that, because that would lead on to more uncontrolled irrigation, more fluid going in. So I would stay away from AC maintainer. And though most often just putting in an instrument and lifting up the pupillary edge itself might allow the neutralization of the pressure between the anterior and the posterior to the iris. Sometimes if it's recurrent in a very high myope, just slipping in an iris hook in any quadrant of convenience and tenting up the iris in one area will completely control this and make the surgery much more regulated. As far as IOP ramp is concerned, I think that's what Saurav was basically referring to, and that's what we are able to do in machines where we have a preset IOP, where the intraocular pressure that is set, whether it's 20 or 30, whether it reaches in 1 second or 2 seconds, you are able to control it. And obviously, in these high myopes, you would like it to go ahead and happen in a much slower manner, and that would make the surgery a little more controlled, apart from the other factors.
Dr. Ramamurthy, I would like to ask one question. Would you like to use, how many iris hooks would you use? Because if you use one iris hook, and that will cause some constriction and uneven constriction. Would it be one, or would you like to add 2, 3, or maybe 4 for that matter?
Obviously, the pupil comes down. Very often in this iris retropulsion syndrome, what happens is when the fluid flow is there, then it becomes the pupil actually enlarges, bloats up. So in these cases, I would just, the idea is for the pupil not to get stuck onto the anterior capsule. So if I just tent it up one area and still there is adequate visualization and I'm able to, because every time you introduce fluid, the pupil does enlarge and you are able to obviously carry on with the surgery. But as you said, if it's irregular and you want better visualization, slipping in one more iris hook might be a good idea. Both of these I would do, assuming that I'm operating from the temporal direction. I'd put in the nasal meridians, lower nasal and upper nasal. Maybe the first hook could go in the upper nasal, and I think that should suffice. I've done it in a couple of instances. But maybe if you say visualization is compromised, maybe one more hook might have to be slipped in.
I would believe that just even lifting up the iris off the anterior lens capsule itself would suffice, then going in for an iris hook. But there are certain situations the pupil really comes down, so we need to look at it. So thanks a lot, Dr. SUMEET, and do stay on with